Okay, I wasn't sure if you would recognize me now. I have my whole career started with TSMC. Glad to see you again. I know, I'm like, do you want to come to dinner? And she's like, yeah. And I'm like, and then she's giving a lecture for the EM group today. And I was like, it's terrible. So, I mean, yeah, that's 3 hours fast. Right. Yeah, I mean, yeah. Okay.
Get started. Kavita, I was waiting for you. Just say. The recording is on. It's started. Good morning. Welcome to Grand Rounds. My name is Suresh. I'm with the Divisions of Emergency Medicine and Health Informatics, and it's my pleasure to introduce our guest speaker today, Dr. Charles Macias. Dr. Macias is the Chief Quality Officer and Vice Chair of Quality and Safety for the UH Rainbow Babies and Children's Hospital in Cleveland. He's a graduate of Stanford University, UT Southwestern Medical School, and the University of Texas School of Public Health. He's a tenured professor of pediatrics at Case Western Reserve University School of Medicine and serves as the Division Chief for Pediatric Emergency Medicine at Rainbow Babies. Dr. Macias has authored over 150 peer-reviewed articles and is a co-editor of the McGraw-Hill Textbook of Pediatric Emergency Medicine. His most recent national and international work in quality and safety includes serving as co-chair of the IPSO, which is Improving Pediatric Sepsis Outcomes, QI Collaborative of the Children's Hospital Association, and as immediate past chair of the American Academy of Pediatrics Board Committee on Policy, overseeing the development of AAP's clinical practice guidelines, technical and clinical reports and policies during his tenure on the board of directors of the AAP. Dr. Macias is an expert in pediatric readiness and disaster preparedness, overseeing over $80 million in federal grant funding for leading 3 key national centers, including the Pediatric Pandemic Network. His talk today assumes added significance given that this week is National EMS Week, and yesterday was actually EMSC Day, Emergency Medical Services for Children's Day. Please join me in welcoming Dr. Charles Macias.
Thanks, Suresh, and thank you for the call out for the EMSC program. It is a reauthorization year for the EMSC program. There is legislation that has passed the House. It is in the Senate. So just putting it out there, it is the only entity, as you will hear, that oversees ill and injured children within the federal government. All right, so a few acknowledgements for conflicts of interest. Funded through the EMSC program under Maternal Child Health Bureau, as well as HRSA and the Administration for Strategic Preparedness and Response. So the content presented here represents my perception and that of our networks and does not represent the official views nor endorsement by ASPR, HRSA, Health and Human Services, or the US government. All right, so our objectives really for the next 50 minutes or so are to describe the evolution of pediatric disaster science and the structures in place to grow and to support pediatric disaster resiliency and everyday readiness, to describe the need for a coordinated national disaster management strategy for children specifically, to discuss the role of data in disaster management, to describe the role of health system improvement and how health systems need to be more resilient and how to get there, and finally discuss the pillars of the Pediatric Pandemic Network. Throughout the presentation, there are several embedded opportunities, things that you can take advantage of, pilot grants, et cetera. So please note those. I hope that the slides will be available because there are several resources on there that many of your physicians, providers, and otherwise staff members would be eligible to participate in and receive separate funding for. So why pediatric readiness? Well, children certainly, as we all know, are a vulnerable population. They represent 25% of the US population. And in order to build resiliency within systems of care to help children, we have to think differently about the way we transform healthcare. We have to think not at how we change each intervention at the bedside, but how we do that by changing and making entire systems of care more resilient. Unfortunately, our current concentration of resources in urban hubs still drives these bastions of pediatric disaster knowledge and pediatric disaster readiness through the 199 to 208, depending how you classify those, children's hospitals across the country. So it's important that we who understand and know how to best care for kids can build that resiliency across the communities we serve in the over 4,000 hospitals that exist in the US. There are gaps currently in interstate coordination and systems of care. And so that becomes essential when you look at these density maps, most of which have children's hospitals, but you look at the wide geography that's never touched and never supported by pediatric services. And this is the equity gap that we see with regionalization or the need for a different model of care. Couple that with what we know from the National Pediatric Readiness Study, and that is that in the last decade ending in 2020, there have been a closure of over 1,000 hospital beds for pediatrics for children across the country. That means we are shrinking our capacity and our capabilities to manage children in disasters and for everyday readiness. And in fact, that is the key, that we need to learn to become more pediatric ready. Couple that with the understanding then that if we are going to advocate for legislative changes, if we are going to change policy, that we have a shrinking proportion of people of interest for us, that is ages 0 to 17, as you can see there, where the proportion of people age 65 and over is increasing, making it politically challenging to make these legislative changes. On top of that, a growing need for equity, as you see a decrease in the lower graph of white children versus Hispanic and a leveling of Black children. So all the more important that we also address equity in our policy and advocacy. So what do we know about the unique needs of children? Well, from the National Commission on Children in Disasters, published and disseminated by the Agency for Healthcare Research and Quality about 5 years post-Katrina, and primarily driven as a burning platform by the challenges that we saw after Hurricane Katrina. And that was, by the way, my foray, working in Houston in the Astrodome, caring for the children that we relocated from Louisiana. That the children were particularly vulnerable during disaster, anatomically, developmentally, and could even become targets themselves of scams and cons. There are gaps in preparedness at the hospital level, at the agency level, communities, government, states, local, and federal. Many institutions lack appropriately sized equipment or personnel to support pediatric services. And critical pediatric procedures are performed so infrequently in many cases in critical access hospitals. We're talking about hospital emergency departments that may only see 3 to 5 children a day. How do you build resiliency with those kinds of low volumes? Many unique issues, in fact, also drive special considerations, such as the need for reunification. We saw a lot of this at our Astrodome site back in the post-Katrina time, where children had become separated from their families. And strategies that specifically are built a priori to prevent the separation or to address ways to reunify are also important in healthcare systems. But we've learned a lot, and while I mentioned Hurricane Katrina, we've learned a lot from school shootings, from bombings, from mass casualty incidents. In fact, disasters are not rare. In the period ending in 2020, over a decade, we saw greater than 119 natural disasters defined as the consumption of resources of greater than 1 billion. So probably isolated to the Gulf Coast? No, absolutely not. What you see here is 20 disasters illustrated on this map with a wide geography, numerous types here, all natural disasters, but 20 in 2021 alone. This affects everyone. We have to become pediatric ready and disaster prepared. So what did we see during COVID, where we learned some of our biggest lessons about global pandemics, global endemics, and global health threats? Well, we certainly saw increases in behavioral health volumes. Emergency departments were experiencing already a 35% increase in behavioral health encounters. Couple that with the isolationism that was being seen during the pandemic, and that exacerbated much of what we saw in behavioral health. In fact, in the first year of the pandemic, over 160,000 children had experienced the loss of a primary caregiver. The impact devastating, of course, to the families, to the children, and to the country. There were gaps in community engagement. E-health entered as a must-have. I don't know what your institution engaged in, but we went from a handful of telehealth visits to 99% of all our visits across our healthcare system ramped up within 3 months with a provider base that was completely unaccustomed to virtual visits. Really unique. We were also seeing disparate access to resources, really exacerbating the inequities in care that were already existing within our healthcare systems. So those that could actually access healthcare and those who needed healthcare the most became at polar opposites of what we could actually provide within our healthcare systems. Layer on that, a staffing and workforce, the great attrition in healthcare, 18.5% of the healthcare workforce disappearing, and all of a sudden creating nursing shortages, physician shortages, a real challenge. Bottom line, as you see there, what Congress saw was a gap, that we needed a coordinated national pediatric everyday readiness and a coordinated disaster readiness strategy for children. So what does that mean? What does that look like? I'm going to take a step back and talk a little bit about quality improvement principles. And when we talk about microsystems of care, we're talking, and that's the lower one, we're talking about a combined unit where providers, where staff members, and where patients all have a commonality. So I have urgencies, emergencies, an emergency department, emergency care providers, that's a microsystem. A critical care unit is a microsystem. When we talk about a mesosystem, that's when microsystems come together to form, let's say, a children's hospital. An internal macrosystem then becomes an aggregate of multiple hospitals, such as UPMC, an external healthcare system, a regional healthcare system, a state government healthcare tie-in, or the federal healthcare system, the US healthcare system. So when we talk about readiness, we have to be able to build readiness at every system level in order to build resiliency within healthcare. We have methods to be able to address that. Pediatric readiness as a policy, and many of you may recognize this policy statement from the American Academy of Pediatrics, the American College of Emergency Physicians, and the Emergency Nurses Association, entitled Pediatric Readiness in Department EDs. It has been the basis by which we can measure pediatric readiness outside of children's hospitals and truly within children's hospitals, but we all do it well. It's really understanding the catchment for the associated hospitals within our system or outside of our system and how we affect those. And that really happens across these 7 domains of quality improvement. How we're providing competencies to providers that may not see children as frequently, or even those that do, how we can step up a level of care, as many of us had to do during the pandemic, really reaching outside of our normal scope of practice. Quality improvement. Do institutions have a quality improvement base to the work they're doing? Do they have policies, procedures, and protocols to manage children for sepsis, for example? Is there a place for patient and medication safety specific to children in adult emergency departments that may not be using weight-based dosing and not accustomed to it? Are there support services for children, child life, social work? And then finally, equipment, supplies, and medications. Are they of the right size? Are they readily available? And do people know how to use them? These may seem pretty basic, but when you're in one of those critical access hospitals and you don't see children frequently, it becomes critical that you know where your equipment are, because you may not have the hours to find it when that critically ill sepsis patient comes in, or when that gunshot wound to a child enters into your hospital emergency department. So the National Pediatric Readiness Project, capital P, capital R, takes this concept of pediatric readiness, building resiliency within our healthcare system to manage children, into a formal program. That formal program has included a survey of over 4,000 hospital emergency departments since 2003, where the baseline data exists. It happens within those 7 domains of quality. There have been 3 total surveys. It has been funded in the millions by the Emergency Medical Services for Children program over the almost 3 decades now that it spans, supported by those 3 entities, and most recently adding on the Pediatric Pandemic Network. What do we know from those readiness scores? The first thing, as we're seeing more emerging data, and actually some of these data were generated by researchers here at your institution, is that there's a quarter of the mortality rate of critically ill children at hospitals that score within the top quartile in that pediatric readiness score. So we're beginning to see a science that, from a medical perspective, we do better as a healthcare system when our hospitals are pediatric ready. And that is seen in U.S. trauma centers as well. A weighted pediatric readiness score of 93 carries with it a risk of death that decreases by 50% in our U.S. trauma centers. So we're now beginning to talk about mortality and survival rates by becoming pediatric ready. And that's true over time as well when we look at both short-term and long-term mortality, as is illustrated here. First quartile is the dotted line above is the dashed and dotted line. And then you can see the opposite in each of these quartiles. So 60% lower odds for injured children, 76% lower odds for ill children in hospital death in high readiness emergency departments. How does that relate to disaster readiness? Same surveys, subset of questions that you see illustrated there on the right. Prior surveys have demonstrated that over 50% of U.S. hospitals do not have disaster plans that include children. So where is the call to action? Solutions certainly have to address systems of care, because the reality is, if you can't care for a child on a random Tuesday, how can you possibly expect to care for children during disasters or mass casualty incidents? So using a quality improvement framework, we can think of a Donabedian structure or Donabedian framework, where structure, that's the physical and organizational characteristics of an institution, a healthcare system, a mesosystem, a macro system, illustrate what's in place. The transactions between families, between providers and patients then represent processes, and structure processes get us to the outcomes. We like to say in quality improvement that every system is perfectly designed to get the results it gets. And that's exactly the truth, that if we have structures and processes that are not correctly addressing the needs of children, we can't expect the outcomes to be any better than what we've invested within those structures. So where has the legacy of national pediatric readiness investments been? Secondary to legislation in the late 60s and early 70s that created EMS systems and emergency management systems, secondary to gaps in trauma care and cardiac care in adults, we saw a massive investment in hospital emergency department care and pre-hospital systems. But it would be 20 years until we actually saw legislation that would support an attention to the same systems to become more ready to care for kids. So that first legislation was introduced in 1984, where the authorization of the EMSC program, Emergency Medical Services for Children, was created, sitting under the umbrella of Maternal Child Health Bureau and the Health Resources and Services Administration. Let me remind you, children constitute 25% of our population. That total investment for the EMSC program in 1984 was slightly over $2 million. The only entity that would oversee ill and injured children in the entire U.S. healthcare system within the government. The first EMSC grants were awarded to 4 states in 1986, and we began to see a growing of that investment with targeted issues grants offered in 1981. It was about a decade later that a new Emergency Medical Services for Children data center was created, which now sits in Salt Lake City as the EDC. And then EMSC State Partnership Program grants were created to create a foundation for all of this work. There are 57 state and jurisdiction offices across the country, and we partner with each of those to build a better network and a better foundation of everyday readiness and emergency care. The PCAR network began in 2002, and that brought us the science that you hear of today, now funded with over $100 million, our closed head injury rules that we know so well, the lack of utility of steroids in bronchiolitis, or scoring scales for croup, a lot of high impact research that has emanated from the PCAR network. We launched the National Pediatric Readiness Project with a quality improvement arm, not just an assessment, but a gap closure strategy in 2002. In 2012, and a similar activity began a ramp up for pre-hospital assessments, or a survey of the nation's 17,000 pre-hospital systems to understand how pre-hospital agencies could better care for children. Small fact, on average, pre-hospital providers, which are the first encounter to pediatric emergency in the home, get about 10 hours of pediatric training before they become EMS providers. So our need to really enhance our systems of care become critically important. So ASPR, the Administration for Strategic Preparedness and Response, launched its 2 pediatric disaster centers of excellence literally months before the pandemic hit. And those 2 centers were, as you'll see in a second, were to create regional models of disaster readiness. And then the Pediatric Pandemic Network was created in 2019. So consider this roadmap parallel to what we see investments on adult healthcare systems. So the EMSC Improvement and Innovation Center has 2 coordinating centers, one at Dell and one at UH Rainbow. And it works in 4 domains of care: pre-hospital care, hospital-based care, trauma care, and disaster preparedness, with this foundation of the 57 state and jurisdiction offices. What is unique about the systems is that they're quality improvement based. Why quality improvement? Because the traditional models of federal technical support centers were very passive. And what we needed to see was a greater time for evidence generation to action. If you allow the passive uptake of science, we may be 13 to 17 years before you actually see that work operationalized. We can shorten that time in guidelines and quality improvement collaboratives to 3 to 5 years, therefore bringing the greatest research and the greatest knowledge into the hands of those that can actualize or operationalize that science more quickly. In addition to that, the Pediatric Disaster Centers of Excellence from the Administration for Strategic Preparedness and Response was designing a strategy to create regional models of resiliency across state lines, so that in 2 regions of the country, we could begin to understand how to make healthcare systems more pediatric ready. Why is that? Specific disasters seldom respect state lines. They seldom respect jurisdictions. They seldom respect regions. And so our ability to partner, to have healthcare portability of our data, to understand what information looks like across systems and across states, credentialing, verification, all of that really has to be addressed in disasters to make our systems more responsive with the currency it needs. So Congress supported the Pediatric Pandemic Network through a SPRAN's authorization. The significance of that being that it is a line item for a congressional appropriation for special projects of regional and national significance. The first grant was awarded at $10 million a year to UH Rainbow. That was increased to double the capacity of the pandemic network to 18 million. And that included 5 additional sites with an anchor at Children's National. And then in 2023, the recognition that we needed an enhanced pediatric science around disaster research and resiliency grew the authorization to 25 million a year. So the total investment now for the federal government, where it was 2 million in 1984, now sits at 100 million that has been appropriated over the last year and a half. That is significant, and that looks like this on the map. You see outlined the 10 hub sites of the Pandemic Network, Seattle Children's, UCSF Betioff, Intermountain for primary children's in Salt Lake, Children's Mercy in Kansas City, Cardinal Glennon in St. Louis, Lurie Children's in Chicago, Children's of Alabama in Birmingham, Norton Children's in Louisville, and then the 2 anchor sites, UH Rainbow in Cleveland and Children's National in DC. What you also see are the other network investments, the 3 ASPR Pediatric Disaster Centers of Excellence and the EMSC. This map had 2 points on it 5 years ago. We are seeing opportunities that we have never seen before. And so this is my challenge to you. How do you become a part of this? And so I'll give you some specifics in a second. So the Pandemic Network has a number of activities that it engages in, but it does so within these 23 task forces that are comprised of over 100 subject matter experts across the country. Of course, the largest of these is the disaster management domain that looks at and strategizes around building capacity and capability to manage children in surges, chemical, biologic, radiologic, and nuclear threats, deployable assets or DMAT teams, drills and exercises, which are a staple of the way that we simulate disasters, health information portability across state lines and across market competitors, reunification strategies for children, and how to manage the threats of supply chain. And we all felt that during the pandemic. The other areas you see are operational and service cores, but they include expertise in infectious diseases, and mental and behavioral health and pediatric readiness, telehealth, and trauma. So the goals of the Pandemic Network to link children's hospitals to become the champions of emergency preparedness across the country and to engage their catchment areas, to ensure health equity with our community partners, to improve emergency readiness of healthcare systems everywhere, to eventually capture 90% of all children's hospitals as part of the network, and to increase the capability of telehealth systems, and finally, to accelerate the real-time dissemination of research-informed pediatric care. Our core activities are providing training and support tools. I would encourage you to go on our website. There's a lot of curated disaster-related AI-driven search engines so that you can find exactly what you need within those sites. A lot of sharing of best practices. We run a number of quality improvement collaboratives, encouraging collaboration instead of competition, using systems-based approaches to align priorities and strategies. So this is quality improvement training, and then promoting equity, inclusion, and cultural relevance. So what does that specifically mean? We are charged to respond and to support in the threat of any kind of disaster or potential disaster. We provide expert opinion. We disseminate vital information, create usable, digestible guidelines, strategies, infographics. It's a lot of pediatric-based advising to healthcare systems that may not have those resources. It's spreading the good work that we do in children's hospitals across the other 4,000 hospitals within the country. And we work within these domains. What have we specifically addressed? Growing threats within a week or two of Omicron, addressing misinformation, staff shortages, running town halls across multiple healthcare systems to bring CEOs, CMOs, CNOs in to discuss how to better engage in the pediatric needs of their populations. We addressed boarding, the reduction in pediatric beds over the decade that we talked about. We've managed strategies around cyber attacks, mass shooting, measles, weather threats, the Maui wildfires. Every day, we're called on to do a number of information sharing, dissemination, guideline sharing. So with these partners, we've developed these high reliability resources, and you can see where many of our investments specifically lie within those hub sites of the children's hospitals and our now three key anchor partners that have expanded to Nationwide Children's, Dell Medical School, and a number of other institutions, including Yale. So our key priorities, as aligned with the federal priorities of HRSA, the ASPR, and the Maternal Child Health Bureau, remain infectious diseases and disease outbreaks, mental and behavioral health, emergency and disaster management, health equity and community engagement. And this year, these were our 2022 and 2023 federal priorities that we've aligned with. The fifth, then, as the feds have layered on, social determinants of health and how we bridge gaps around care with social determinants. So embedded in all of that work, and the way I think of this, the way many of us sort of do the 10-second elevator speech, is that the ASPR is charged with lights and sirens. They're the ones that respond rapidly. The softer, bringing in communities, families, schools, that's the HRSA end of the work. So across federal organizational participation, we can address special vulnerable populations, children and youth with special healthcare needs. So when you think of children and youth with special healthcare needs, 20 to 25% of the pediatric population, without that, children within that, children with medical complexities comprise about 1 to 5% of that population. They're specifically vulnerable because they, of course, rely on equipment, supplies, durable goods, et cetera. So we've conducted a number of town halls, and what you can see is what remains. Key issues that children and youth with special healthcare needs don't have a seat at the table for state or national policies, and we have to look at better ways to incorporate their interests. We have gaps in national agendas and advocacy efforts to partner with national organizations like FEMA. We need better materials and implementation of dissemination strategies to reach families. We need better education of providers, and that we also need to establish recommended standard protocols. Because as we learned in this surge, our most critically ill patients are not always going to come to the children's hospitals. Sometimes we have to have contingency plans for maintaining their care in the communities. And this is a special population that needs that. So what are some of the examples of the ways we've done that? The STARS program in St. Louis is a system of tracking disaster response. It uses an emergency information form, much like that was recently published by the AP policy, describing what kinds of supports are needed for each child. So it's a tailored profile of a child that gets carried with a child, portable with that child for medication needs, any durable goods, any specific resuscitation needs, and that is trained to pre-hospital personnel within the St. Louis regions that the STARS programs has. So it's a way to move information more quickly and more reliably about children, specifically children with medical complexity. Similar program in Oregon with the HEROES. We're currently working with both groups to spread this across the nation. Other vulnerable populations, mental and behavioral health, through our SciStart tool, an application and web-based tool for post-traumatic stress disorder screening, understanding, and linking to trauma-informed care, but also being able to create surveillance for regions across the country, as you see there on this third screen right here, to understand where there is high uptake and high scores, and we have analytics in those regions to help us understand where do we have particular pockets of mental and behavioral health needs. We are currently engaged now with 35 plus healthcare systems to lead a collaborative around the use of SciStart. But much of this work really has to be institutionalized, and we're seeing that already begin. Pediatric Readiness is now part of the Gray Book. For those of you familiar with the American College of Surgeons verification process, any hospital within the US now that undergoes trauma verification, so like a level 1 trauma center as you are here, must have a pediatric readiness survey done and a gap strategy around it. That call out by the American College of Surgeons to say, wherever you are, even if children are a small percentage of population, you have to be ready for care for kids. That's the message that we want to be sending. We need to incorporate that into our decision support tools, into our regulations, and to our policies. And we're seeing that happen. Similarly, the federal government is building a management structure, the CDC on the public health perspective, FEMA for emergency management, and ASPR for medical response through coalitions, through this work with children's hospitals, through home and family strategies, all built on a foundation of science and data. So what you see then are the federal programs that are now resourced for pediatric readiness and disaster readiness on the right. Those represented in green are funded by HRSA. Those represented in yellow beige color are those funded by ASPR. Perhaps one of the most significant is the newly resurrected National Advisory Committee on Children in Disasters, where real recommendations to policy can be made. So we're grateful to see this change. So at the end of the day, as we know with any healthcare system change, it all has to be data-driven. It has to be driven by the best science possible. And when we think about data-driven strategies around disaster management, it's no different than any healthcare system evolution of analytics. We look at maturity with improved outcomes there on the y-axis, and what you see on the x-axis is systems evolution over time, taking us from data reporting. What is the data that I know about my patient, a lab report, for example, to analytics? What do I know about all my patients with sepsis? To predictive analytics, can I get an alert that will tell me this child is likely to have sepsis? And then prescriptive analytics, do I get an order set that gets pushed out for that? Building this kind of resiliency helps us to take these strategies, these contingency plans into community hospitals, into pre-hospital systems, and even into schools to better manage disease processes. But we can look at sophisticated approaches to disaster management through augmented intelligence and artificial intelligence. Specifically, a lot is happening through machine learning. We know a lot about ventilator allocation and what policies should look like from machine learning models that have been created that help us to understand what would it look like if. Similar, there's a lot of this kind of AI approach to the work that's done with flood hazards and flood risk assessments for neighborhoods. All of that is great, but it becomes very passive knowledge unless it's taken to action. So when we think about data, numbers, information, to analytics, what can we extract? What can we interrogate within that data to better understand, to create insights that ultimately utilize quality improvement strategies to drive improvement? This is true of all phases of pediatric disaster preparedness, response, recovery, and mitigation prevention. So in preparedness, we certainly lack a standardization in this country for assessments, hazard vulnerability assessments. They look different in different states, and yet they're mandated to be done by every hospital. So our opportunity to build better preparedness and understand more evenly how hospitals are prepared to manage children happens within that spectrum or that phase of the disaster cycle. Within response, we have static data that we know from relationships with other entities that tell us of what past models might have looked like. How did the system respond? Where were the gaps in mortality? Where are there gaps in the community hospitals, for example, to more dynamic data? What do we know from situational awareness and situational reports that may happen in a hospital incident command system 2-3 times a day during a disaster? And then in the recovery, we need broader data points. We need the ability to bring disparate data sets together to understand how we can recover from disasters. And I'll give you a couple of examples of that. And then finally, mitigation and prevention. There's a lot of opportunity for understanding what creates resiliency within organizations and healthcare systems if we could more effectively use data. So what does that mean when we talk about the use of big data? When we think about where we have been and where we're headed with disaster-related data, Big data, defined as high volume, high velocity, high variability, can influence very dynamic, complex models of data that ultimately you want taken to policy change, because that's where the actionable impact is going to occur. So what you see on the bottom left is the illustration of the recovery of San Juan, Puerto Rico from Hurricane Maria. Not surprising that you can look and drive in their drive-throughs to recognize data points that talked about normalization of life post Hurricane Maria from physical assessments. But the cool uses of data are looking at cell phone and social media to understand where life gets back to normal. So how we use social data, for example, begins to create more complex models. The one on the right represents a vulnerability of countries and how they responded to COVID. And you can see the resiliency to natural disasters, to healthcare threats, to mass casualty incidents represents a vulnerability index. And what they saw with COVID numbers represents exactly what we would expect to see. The point is, we need to begin to be able to put complex socioeconomic models that combine not just healthcare data, but all aspects of data to understand what disaster resiliency looks like. So to that end, the Pandemic Network has now had a multi-million-dollar investment in creating a national data portal. And you see bits and snippets of that. This is forming the foundation of a data portal that will allow us and has allowed us to support quality improvement collaboratives with self-service analytics and multiple collaboratives at a time. It is also the same data portal that has and will allow us to combine surveillance data and operational data. So lots of opportunities there for people that are interested in accessing the data portal at no cost. But ultimately, what are we hoping to do? To transform pediatric disaster medicine. And we do that more quickly, as I defined before, through quality improvement strategies, really not allowing passive uptake, but very actionable, very deliberate uptake in a shorter period of time. So we use improvement science to drive that. We have been using quality improvement to build organizational reliability for many, many years. And for those of you that operate in quality improvement enterprises, the concept of high reliability organizations is not new to you. But 5 tenets of a high reliability organization: a deference to expertise, where we have informed decision makers and are constantly educating the workforce; a reluctance to simplify, creating structures that can address the necessary complexity and the inclusiveness of surveillance through data and analytics; a sensitivity to operations, building an ongoing communication and situational awareness so that you always know what is happening within your healthcare system. Show of hands, how many of you during the surge felt like you had a good grasp on a daily basis of what was happening in healthcare? Pretty much how we all felt. Unless you were sitting within that HICS room, within that hospital incident command room, hearing the situational reports. We need to get that information out to the hands of the people that are using it. So building high reliability healthcare systems is a critical way to think of that. A commitment to resilience, that we are executing on action plans, that we are building and empowering teams to better understand collaboration. And then finally, a preoccupation with failure, really embracing the need to address failures or potential failures on a constant basis in a quality improvement sort of strategy. So research informs much of how we build high reliability organizations, and that's primarily embedded within health services research. So I like to think of health services research simply as how organizations, technologies, social factors, finance systems, and personal behaviors get from there to the outcomes that we hope to achieve. What is that translation? How does a guideline get implemented to actualize improvements in outcomes? That's where health services research comes in. And it becomes a staple of the way that we think about disaster science. So the management, the daily operations of healthcare delivery crosses over and is dictated by policy, either policies we create or policies that have been dictated to us by federal legislation, by state legislation, hopefully all informed by research. And that Venn diagram really shows our opportunities for enhancing pediatric disaster science and disaster research. At the foundation of all of that work is ultimately the translation to what we do on the front line, the Plan, Do, Study, Act cycles. How do we build resiliency around sepsis, for examples, in community hospitals that may not be managing children every day, because that's where the more critically ill patients may end up and may not be able to get to us as they did or didn't get to us for many of our institutions during this surge of 2022. We do a lot of our improvement work through quality improvement collaboratives. Quality improvement collaboratives are networks for shared learning. They translate research into practice. They allow us to discover new knowledge, best practices, and they allow us to close the quality gaps and improve care and outcomes in real time, not waiting for 13 years for a publication to have uptake, but to really drive that science. And there are 7 components of an effective quality improvement collaborative: that it is being driven by evidence-informed content, by quality improvement, by project management. 3 data components: that it has an effective IT infrastructure, data management strategies, and effective analytics to extract from it. And then finally, that research is pushed out and disseminated. So easier to think of it when you think about specific disease processes. I've had the privilege of co-chairing the Improving Pediatric Sepsis Outcomes for 7 years until we sunsetted it in 2023. I see Chris there in the back, and Joanna, who have participated in this sepsis work for many years. We had 66 participating hospitals, as are illustrated by all these bubbles. The size of the bubbles illustrates the size of the children's hospital that was involved. At our current estimate, that collaborative has saved over 570 lives. We've seen an 81% decrease in sepsis, and we've saved over 72,000 hospital days and 3,500 organ dysfunction episodes through the work of the collaborative. The point being, if you wait till the science is driving all your care and that science is published, you'll be waiting 13 to 15 years. That's not soon enough. We need more collaboratives, and that's exactly the strategy we've taken with disaster preparedness and disaster science. What you see here are preparedness scores for one such of those collaboratives that looked at improving pediatric and disaster preparedness, clinic-based and hospital-based, with an increase in knowledge over time. We see the same with our disaster networking collaborative that just closed, which really helped organizations and healthcare systems engage and improve in their pediatric disaster planning. You remember I said that over 50% of the nation's hospitals don't have children included in the disaster plans. We've strengthened the infrastructure for preparedness, assessed gaps through environmental scans and formalized gap tools. And they've had the opportunity to network and prepare with experts from across the country. You can see the over 100 children's hospitals that participated in that collaborative across the country. What this doesn't show is we actually had a number of international sites as well that opted to present. And you can scan the QR code if you want to see more information about the work that happened in the disaster networking collaborative. Now moving from building structure in that Donovan framework into improving processes, we move into the disaster response collaborative that launches this August. We're in the preparation phase. It'll focus on 4 areas: building surge capacity, understanding triage and decontamination, understanding evacuation, and creating plans for reunification in the course of separation. So all told, when you layer all of our quality improvement collaboratives, you see the number of quality improvement collaboratives that we're leading in this space, trying to introduce into healthcare systems across the country, into community hospitals, what we do best in children's hospitals, really be thinking about resiliency. But is that enough? We don't have enough science. The bottom line is there's simply not enough published literature, not enough science in pediatric disaster resiliency or in everyday readiness. So when you look at that National Commission on Children and Disasters report from 2010, what you will also see is that in addition to those needs for national disaster planning along mental health, the need for pediatric medical countermeasures, the need for better medical capabilities, and for surge capacity is the need for a better research agenda in pediatric disaster science. Other needs are outlined, not surprising, by the commission, but specific to pediatric disaster research are challenges and a paucity of risk-benefit analyses, funding, institutional review board approval, and not understanding how IRBs not understanding what disaster science looks like, participant recruitment, informed consent. The list goes on. Very unique to disasters. So how do we overcome that? Are we already seeing a change? What you see here is our scoping review of the pediatric literature. 684 pediatric disaster peer review articles were found in our search. It was actually over 1,000, but we reduced that down based on format and type. Literature was clustered into preparedness, response, recovery, mitigation, education. Most of the literature published in pediatric disaster science emerged after 9/11, and then the bulk of it you see there in B, a big surge in pediatric disaster science after Hurricane Katrina. We hope that we can continue to drive those increases in the literature as we have seen over the last 4 years. Most of that work is in preparedness and in the response phases, so we lack a significant amount of literature to drive the science and the actionable implementation strategies for recovery and mitigation. And so that will be part of our focus. But that means that we have to implement strategies for pediatric disaster science to grow the science, the research, and the innovation. So the PPN is bridging those gaps in pediatric disaster science. We have a Delphi conference with subject matter experts across the country planned for July of 2024. We will be bringing in subject matter experts for this modified Delphi process to look at those 5 domains of work in preparedness, response, recovery, mitigation, and education. And its outputs will certainly be widely disseminated. This is coupled with the work that is being done in partnership with the National Academies of Science through their action collaboratives to better grow that science. I had the opportunity, I know Chris participated in the first NASEM priorities meeting to better understand pediatric disaster science and understand strategies to grow it. We've built a pediatric disaster curriculum. We currently have our first cohort of 17 participants from across the country to develop that disaster science curriculum for advanced learners. We also sponsor the EMSC and Pediatric Pandemic Network Scholars Program. The application process opens every 1 to 2 years for our PPN scholars, every year for our EMSC scholars. We identify projects, we support through mentorship, we have monthly meetings, we have products and presentations for dissemination as well. Our scholars come from multiple specialties, and from across the country. These are our current EMSC scholars, these are our current PPN scholars. I just wanted to show you the breadth of professions and the breadth of locations that they come from. We recently announced our Pediatric Disaster Research Career Development Program, funding what we believe to constitute about 50% protected time for career development awards. We're awarding 4 of those. This round just closed about a month ago. We'll be announcing those career development award winners soon, but we plan on creating 4 more career development awards next year as well. We have a pilot studies program, 11 pilot grants of $50,000 per year times 2 years. We awarded 11 of them in 2023. And as you can see from this table, they spanned every kind of type of research, easily available without the kind of competition that you would see at NIH level, really attempting to grow a very fundamental basics of pediatric resiliency and disaster research and pediatric preparedness work. We have pediatric pandemic-wide research initiatives looking at the scope and impact of COVID on mental and behavioral health across 10 hub sites. We have implemented interventions that will better prepare communities for future disasters and create community-based participatory research framework as well. We are partnering with other networks, including CTSCs and the PCAR network, which we talked about earlier. We also host an annual research and innovation conference this year. Will be in Birmingham, one-day conference if you're interested in that as well. Coming soon, research on regulated medical devices and software in our innovations end. We recently entered into a grant proposal for a place on the BARDA Accelerator Network. While we haven't been told yet that we have received that, we were notified that we had the highest score of anybody that applied. So assuming that the funding continues, I think we have a pretty good chance. But the point is that we will be offering through this innovation arm $50,000 a year grants per year, $50,000 per year for up to 2 years for medical devices and medical countermeasures. So an opportunity to fund your innovation work. All told, when we look at this cycle of taking basic knowledge to clinical knowledge to high quality outcomes, our primary focus is in clinical studies through quality improvement through T2, T3, and T4 work. This is where we see our opportunity for pandemic network investments. And through these 23 domains of work, I think that we have provided multiple opportunities for participation either at the hospital level, at the healthcare system level, or at the provider level. And we certainly are happy to have anyone join us. So we'd love to see you guys have that star there in our work. If you're interested in hearing more about the Pandemic Network or disaster preparedness, the framework that the country has taken for this recent investment, I would encourage you to scan this QR code. Ready, Prep, Go is our podcast, regularly done. It emanates from our site in DC, and we're happy to have hosted our first 3. And looking forward to what the future of that could go. Many, many resources on the PPN, on the EIC, the Pediatric Disaster Centers of Excellence, Rapid Region 5 for Kids and Gulf 7. If you want to learn more about pediatric readiness or disaster readiness, go to any of those sites. And I will open it up for questions.